in Boston. I'm joined by two esteemed colleagues, which we'll go through in a second. But I just wanted to mention before we start that the way we will do question and answer for the session, and I really do hope that people will pose questions and facilitate some discussion, is through the QR code here that you see on the screen. So if you can take a picture of that and log in to that, it will allow you to ask questions. And that's true for the people in the room, and obviously this is also true for the large number of people who are present online. And again, we will try our best to finish on time so that we have plenty of time for discussion at the end of the presentations. All right, so again, today, really our focus is on pancreatic cancer. I think it's an exceptionally exciting time in pancreatic cancer. It has been a hard slog, right, as many of us know who care for patients with this disease. It's such an aggressive cancer, so difficult to treat. But really, things are changing, right? And I think really the timeliness of this session is clear. As we saw some of the data presented today, including Dr. Wainberg, who presented some of that data. And we'll try to review some of those data around RAS targeting, but I think there's also other things too, right, that are finally starting to change in pancreatic cancer, where we really do start to now have the options coming for targeted therapies in this disease. And I would also say some approaches at immune therapies and vaccines and others. And really exciting to see. We've waited a long time. A lot of people have done a lot of hard work to get to this point. So again, I'm Brian Wolpin. I'm at Dana-Farber Cancer Institute and Harvard Medical School in Boston. I'll help chair the session today. And then we have two really incredible faculty and two people I would consider friends. We have Eileen O'Reilly, who is an outstanding medical oncologist at Weill Cornell and at Memorial Sloan Kettering Cancer Center. You can see her titles on the screen, really an authority in pancreatic cancer and in therapies for pancreatic cancer. And we have Zev Wainberg, who you can see is from UCLA, professor of medicine and surgery. That I actually didn't realize until I saw the slides. He's also a professor of surgery at UCLA. Again, really another authority in the country and internationally in pancreatic cancer. So really I am looking forward myself to hearing their talks, hearing about their interpretation of data that are coming, and really help us sort of walk through what is the current and what is changing in pancreatic cancer. So here's the agenda for us today. We are in the midst of agenda item number 1, so the welcome and the introductions. Dr. Wainberg is going to lead us off. He's going to talk a bit about current therapies in pancreatic cancer and a number of directions that are being followed to identify new therapies for patients with this disease. He's then going to turn it over to Dr. O'Reilly, who's going to focus in on RAS-targeted therapies in a number of their different varieties and really help us focus in on how those treatments may change how we care for patients with pancreatic cancer. And then I'm going to use what time is left to talk about what the future may bring. I'll recap a bit of things that Dr. Wainberg and O'Reilly discussed, give you a little sense of how we've been thinking about personalized therapy in pancreatic cancer, and go a little more in depth on some of the RAS inhibitor studies that are ongoing. And then we'll close, and again, really hoping for some interactive discussion after that point. So I'm going to turn it over to Dr. Wainberg, who's going to get us started. Thanks, Ed.
Thank you, Brian, and nice to be here. So I'm going to set the stage, obviously. We all know that this is among the most aggressive and lethal cancers. We probably are also aware that this is an increasing cancer on some level, particularly in the Western world. But it still represents only 3% of all new diagnoses made annually, but up to 8 to 9% of all cancer-related deaths, and this is expected on some level to increase. So, you know, a lot of cancers obviously affect different parts of the world with different variations. This is one in the United States, certainly, and the Western world, which we are quite familiar with. We also know, of course, that the majority of patients are not diagnosed early. Has gotten a little better over the last few years, I'd say. But the majority of the patients who are diagnosed, certainly in the community, are diagnosed with advanced disease. And that still corresponds. It used to be lower than 10%. Now it's gotten a little bit better, but a 5-year survivorship of about 13%. There's a lot of patients, though, being diagnosed in the middle stages a little more, what we call so-called regional disease, whether we call them borderline resectable or locally advanced. We do see a few more patients every year who are found at an earlier stage in the so-called regional stages, which do afford the opportunity to sometimes be treated with curative intent. So obviously, when we talk pancreatic cancer, by and large, we speak about ductal adenocarcinoma, which is, of course, there are other less common variants, such as neuroendocrine tumor. But really, when we're talking about today, we're talking about pancreatic cancer, which is felt to evolve through precursor lesions, whether it's pannins and some versions of IPMN, that gradually evolve over time into cancer. And the cancers themselves are obviously found at the point when the mutations are already fully pronounced. But in fact, in most preclinical studies, mutations like KRAS or even earlier P53 are actually found at the premalignant phases, like Pannin. And so serial biopsies of these patients show that KRAS is a relatively early oncogenic event in pancreatic cancer. And then now we do understand a little bit more about these transcriptional subtypes, such as classical and basal, which do behave a little different clinically and may in fact have different responses to chemotherapeutic regimens. So the standard of care has always been chemotherapy, certainly for as long as gemcitabine been approved for a number of years. Chemotherapy has been the standard of care, remains the standard of care. What's changed is obviously combination chemotherapy and also the recognition that there are subgroups of these cancers in which biomarker testing can really help. We've shown that with both germline and to some extent now somatic. So whereas it used to be uncommon, and you know, I remember even a decade ago, people would never test their tumors for genomic testing because what was the point of finding out they had a KRAS P16 or P53? And now we do have a point, and that's very exciting. And you know, I remember Eileen was one of the early people saying, "Oh, we should start sequencing all these tumors," and I was somewhat nihilistic about it. And now I realize, okay, we both, it was a good idea because now we have options, but also we collected this massive amount of information that can now actually prognosticate patients based on a KRAS, as we'll talk about a little later. So I did draw the short straw here, though, tonight, because I am forced to talk about chemotherapy. And the reality is that chemotherapy, while it has evolved, it's still, you know, quite challenging. And the first-line regimens for patients remain FOLFIRINOX, Gem/nab-paclitaxel. NALIRIFOX also has a level 1 designation, which we'll talk about. And then, of course, there are subcategories where, like BRCA mutations, where platinum-based therapies ought to be considered. And if people have, obviously, a performance status that is inadequate, then we don't necessarily give all this aggressive chemotherapy. Now, what do we know about FOLFIRINOX and Gem/nab-paclitaxel? We know they've been around for over a decade. We know they have a fair amount of reproducible and expected toxicities. We know that they both showed improvements in progression-free and overall survival compared to gemcitabine, which was the standard of care about 15 years ago. In the head-to-head trial that is somewhat of a surrogate for FOLFIRINOX, here in NALIRIFOX, we were compared head-to-head versus Gem/nab-paclitaxel, and this was a large global phase 3 study, which only was presented 4 years ago, feels like a lot longer. But in fact, this study showed an overall survival advantage, small, but a statistically significant improvement of about a couple months of NALIRIFOX over Gem/nab-paclitaxel and an improvement in progression-free survival as well. So that was, and here's the PFS curves, with a hazard ratio of 0.69 here. Actually, the PFS was probably a better result than the OS in some respects. Treatment-related adverse events for this study, I mean, really it boils down to, I think, pick your toxicity with these regimens. With Gem/nab-paclitaxel, it's primarily about cytopenias, primarily about some level of neuropathy. With FOLFIRINOX, NALIRIFOX, it's about peripheral neuropathy from the oxaliplatin and GI toxicities from the 5-FU irinotecan. So it's always a trade-off in toxicities, and some of these we've gotten a lot better at managing over the last number of years. So there have been other studies, smaller studies. Here was a randomized phase 3 study that ultimately closed early, done in Japan, which compared nab-paclitaxel versus modified FOLFIRINOX versus S-IROX. The study actually thought FOLFIRINOX would improve, and when that wasn't the case, the study was closed early. But in fact, there was no difference, as you can see, in these three curves. And in fact, in Japan and in Asia, to a large extent, gem-nab-paclitaxel has become the standard frontline therapy. In the GENERATE study, there were actually suggestions of maybe an improved response with S-IROX, which is a S1 combination, which we clearly don't have in this country. But by and large, there weren't a lot of differences between these three regimens. And again, a significant difference in toxicity profiles, mainly having to do with what we discussed earlier, higher rates of anemia and perhaps thrombocytopenia in the gem-nab-paclitaxel, and of course alopecia, and a little more rates of GI toxicities in the FOLFIRINOX and S-IROX combinations. So we have three regimens that are considered the standard for patients with frontline metastatic pancreatic cancer, and we spend a lot of time, I would say maybe a little too much time, with each patient talking about the nuances between these, and then we try to collectively come together at what is a reasonable best choice for each individual patient. And that's kind of the way we have been looking at it now, up until, of course, this new era when we're hoping to offer much more. So here's the first polling question. A 56-year-old male with metastatic pancreatic cancer receives first-line treatment with gemcitabine and nab-paclitaxel. A scan done after 8 weeks reveals a partial response, which is sustained for 7 months until a follow-up CAT scan demonstrates enlarging lesions, as well as several new lesions in the lung and liver. Despite residual grade 2 neutropenia, he is deemed to have a good performance status. According to the guidelines, which of the following is the most appropriate second-line treatment option for his patient? And I will say that we haven't gone over second-line information yet, so this is a true question. And I guess I'm supposed to pause and wait for the question to be answered by the audience. Okay, so some people said repeat gem-nab-paclitaxel, and a lot said 5-FU, leucovorin, and liposomal irinotecan. Okay, so let's go over some second-line data, because that's a little different. So beyond frontline therapy for pancreatic cancer, I mean, the reality is that while it's gotten a little better, there's only about maybe 40% of patients can get the second-line pancreatic cancer treatment. That has changed, I will say, and I remember probably a decade ago it was far fewer, and nowadays, because primarily of improvements in supportive care, we're able to get more patients to second-line therapy, and the second-line therapy has improved a little. There is limited clinical data. There are remarkably few randomized trials in the second-line pancreatic cancer setting, despite this being such a common malignancy. And survival rates when you get there is quite short, in the 4 to 6 month range. There have historically been no activity with the so-called targeted therapies, obviously until now, this KRAS revolution. So what do we do with second-line patients? So the Category 1 recommendation is based on a study called the NAPOLI-1 study, which is 5-FU, leucovorin, and liposomal irinotecan. That was compared to second-line 5-FU alone in patients who progressed on gemcitabine. Not all of them had gemcitabine nab-paclitaxel because it's a little older, but that became a Category 1 recommendation on the NCCN. A whole bunch of other recommendations based primarily on small studies, retrospective studies reviews. So fundamentally, I think it comes down to what they got in first line and now give them something different in second line. So for example, if they got gem-nab-pac in front line, now Naliri, which is 5-FU liposomal irinotecan, or 5-FU alone. If they got FOLFIRINOX in front line, we primarily use gem-nab-paclitaxel, even though there's not level 1 evidence for that recommendation. It's still the de facto standard of care in ECOG performance data 0 to 1. And here's the NAPOLI-1 efficacy outcomes. You can see that there's about 2-month improvement overall survival from 4.2 to 6.1. This was statistically significant, and this got FDA approval on the basis of that information. Again, trade-off in toxicity with a 5-FU or an irinotecan combination. We're adding more GI toxicity, obviously, than with 5-FU alone. But fundamentally, that became the standard. And so we end up with a sequencing paradigm that looks a lot like this. In first line, you get whatever you're going to get. And I think here, people, certain countries have certain preferences, as we'll talk about. But, and you switch it up in second line. Now, maintenance approaches is used to be something we never thought would happen in pancreatic cancer, but there's a few ideas that people feel is the right way to follow patients for the long run. One of those includes maintenance 5-FU in patients who are on FOLFIRINOX. Of course, maintaining gemcitabine, because we can't keep going with the gemcitabine nab-paclitaxel 3-on 1-off for very long in a majority of patients. Perhaps most importantly, that is relevant for the germline BRCA patients, is there is a role for maintenance olaparib based on the POLO trial. We'll talk about these things briefly. So first, the French did a study to look at what is the idea behind continuing FOLFIRINOX until progression versus dropping off the irinotecan. And I think, by and large, the French are pretty good at doing these studies. They've done them in colorectal, and they did them in pancreatic cancer. And you could kind of see here that there's no difference. So many, many people have adopted the idea of once you get your best value from an aggressive combination regimen with FOLFIRINOX, it's okay to maintain on FOLFIRI. The sequential strategy of switching back and forth wasn't necessarily as productive. In the germline BRCA patients, which make up a small percentage of global patients, but certainly are higher concentrated in certain ethnic groups and in certain urban centers. We know that the PARP inhibitors have a role. This has been somewhat challenging, but we know that in the beginning, when you have a BRCA, inherited BRCA defect, you're very sensitive to platinum. So I actually do like GemCis as my preferred frontline regimen. It's an easier version of FOLFIRINOX, and I find it to be just as effective. And while there's no head-to-head comparisons, I usually prefer that as my frontline therapy for BRCA pancreatic cancer. And the POLO trial looked at what happens after you stop chemotherapy, and keeping in mind that this was one of the first trials of its kind also, about 5 years ago, feels like longer, but the trial randomized patients to either placebo or olaparib, the first-generation PARP1/2 inhibitor. And the concept here is obviously you can't continue chemotherapy forever, and the study met its primary endpoint for progression-free survival. The reality is that it's a very carefully selected population, germline BRCA. It's also very carefully selected in who should get this maintenance approach, and one of the challenges has been implementation of this in the real world when the GemCis combinations can be better tolerated sometimes, and sometimes we're loath to back off if we see the early signs of progression. But the study met its endpoint, and secondary objective of the study was overall survival, which didn't quite meet its endpoint statistically, keeping in mind that many of these patients had a depth of response that was really long, even once withdrew from the gemcitabine cisplatin chemotherapy. That's exemplified here when you kind of look at the long-term survivorship, that it's not too different in the patients who were maintained at 2 years. In fact, the group of patients who were subsequent therapy, the olaparib has some role. Now, I will say a lot of patients I find it's challenging to put them on the maintenance olaparib because they do progress quite quickly. There is almost a platinum dependence in pancreatic cancer, which is very different than BRCA breast cancer or BRCA ovarian cancer, which can't quite be overcome by PARP inhibitors, in my opinion. So selectively, I will recommend the use of olaparib, and quite selectively. The efforts to improve in the BRCA patients include combinations with checkpoint inhibitors. Here's a very small study. It was done at Memorial with pembrolizumab and olaparib, showing nice responses. Can we somehow engage the immune system here in these BRCA patients, as we were hopeful to do? There's certainly something to be said about that. It's actually being looked at in the context of several randomized trials. First is the adjuvant olaparib versus placebo trial, which is the Apollo cooperative group study, along with a SWOG study, which is looking also at olaparib with or without the addition of pembrolizumab in the BRCA maintenance context. Finally, there's I believe still ongoing, this Platinum Alliance study. No longer ongoing, Eileen says. Eileen knows. Okay, was ongoing. I'll let her comment on that in the Q&A period. Okay, what else in pancreatic cancer? Well, I mean, it's not all about KRAS. KRAS is obviously dominant, but there's going to be some targets of interest. I've been interested, for example, in the adenosine pathway for a long time based on some lab work we've done at our institution. But adenosine production, which is a immunosuppressive molecule, immunosuppressant, is very highly driven by pancreatic cancer, perhaps amongst all cancers. And one of the penultimate enzymes involved in adenosine production is CD73. So there have been certainly preclinical studies showing blockade of CD73 and subsequent reduction of adenosine has been correlated with both KRAS mutation and a blockade of a more aggressive phenotype in vitro. We did a study with, Eileen was part of it as well, the phase 1/2 study of Gemnab paclitaxel with quemliclustat, which is anti-CD73 protein inhibitor, with or without zimberelimab, which is a PD-1 inhibitor. It really wasn't quite versus standard of care because they weren't randomized, but they were 3 separate cohorts. And in the previously untreated patient population, we did see that again, compared to what we called a synthetic control, which is a way that a study can not randomize a full population to an absolute control. We did see a improvement in survival compared to a synthetic control. Again, we have to take that with a grain of salt. And that has led to a randomized phase 3 trial, which I will say has completed enrollment with Gemnab paclitaxel with or without quemliclustat, which has actually completed enrollment, fortunately, prior to these KRAS studies. So we actually should be able to have a proper readout of that study in the next year. Okay, finally, synthetic lethality. Synthetic lethality is obviously a topic of some interest in a lot of cancers. Pancreatic cancer also has some interest here. Perhaps one of the ones that's gained interest in the last few years is MTAP, which leads to these formations of these PRMT5 and MTAP complexes. These are complexes that are hard to understand, but generally speaking, probably affect about 15% of pancreatic cancer. They also are adjacent to the CDK2N, so you see a lot of co-expression of these on your genomic reports, but not all CDK2N loss equates to MTAP deletion, so you have to be careful that it has both. Now, I will say that it's not just pancreatic cancer, it's probably 18% of pancreatic cancer. There's a small percentage of gastric cancer and other GI cholangiocarcinoma where this is a relevant alteration. One of the things is that PRMT5 inhibitors have been around for, like 15, 20 years. I think one of the first phase 1 studies I ever did was a first-generation PRMT5 inhibitor, which was incredibly toxic. That was a MTA-competitive PRMT5 inhibitor. Now we have this new wave of these drugs, which are synthetic lethal, cooperative PRMT5 inhibitors. And there's a few of these out there. Now, the first one, or I shouldn't say the first one, but one of the ones is AMG 193, which had a fairly large phase 1 study. Now, we don't usually see high response rates with synthetic lethal targets, so we're not going to see the kind of waterfall plots that we've started to see in, let's say, oncogenic addiction targets like KRAS and BRAF. There we expect response rates. Synthetic lethal drugs with a lot of stable disease. And that's okay, in my opinion, so long as patients are staying on those drugs for a period of time, as long as it's improving median PFS. So here's one with AMG 193 that had some responders, but a decent median PFS. And there have been a few others that are in development as well, Tango and BMS, and so there's some effort there. Finally, there's a whole host of ADCs, and you've heard a lot about ADCs at this meeting. ADCs, bispecifics, but we'll start with ADCs that are of interest in pancreatic cancer. It's not, even after patients get KRAS inhibitors, they actually are all eventually, we all know, are going to progress eventually, unfortunately. So we have to find new things for these people. Antibody-drug conjugates are a good idea because pancreatic cancer is still a pretty chemosensitive disease in some ways. So we have some payloads in these drugs that will make patients sensitive to these agents. These are just a few of them. We're doing a few CEACAM5 ones, and Claudin 18.2 is a highly expressed target in pancreatic cancer as well. So I'll end here. I'll say that we still are at the point where the cancer is diagnosed very late. The incidence is increasing as our population is aging. The 5-year survival rate is still dismally low. I am, like Dr. Wolpin said, I am very optimistic, though, about the future, probably more so than we've been before. And I will pass it on now to the much more exciting topic that Eileen is going to present, which is RAS mutation.
Good evening, everyone. Thanks, Ev. Thanks, Brian, and to you all for coming and those online for listening. Yes, so the topic to discuss is personalizing treatment in RAS-mutated pancreas cancer. And we'll get us started with a poll. So about what percentage of individuals with pancreas cancer have a RAS mutation? Hopefully not too hard. So 5 to 10%, 20%, I think 30, and 95, 60 and 95. Your choices. So a little bit of a split here. Okay, that's good. So hopefully this next part will be educational. So the answer is the latter. Maybe 95% is a little high, but in 88, 90, 94%, depending, somewhere in that range. So just to speak to this topic, about 20% of all cancers have a RAS mutation. So along with P53, these are the two most common oncogenes that are altered in this disease that are predictors of poor biology. And pancreas cancer is the disease of RAS, right? Again, near ubiquitous RAS mutations in this disease. And depending on how you look, anywhere from, again, 88, 90, 94, 95% of individuals will have a RAS mutation. We'll come to what wild-type RAS looks like in a minute. In the GI space, a couple of other things to point out. In the esophagogastric world, we see rare RAS mutations. We do see them, but we see more amplifications of wild-type RAS. In colorectal cancer, about 40% will have a RAS mutation, and biliary tract malignancies and pulmonary cancer are the other diseases in the GI space where these drugs are going to have a role. So stay tuned, and you'll see there's other diseases, of course, as well. But given that we're speaking about GI malignancies and pancreas cancer, we'll focus now in on that. So dividing up RAS, we have three potential classifications. We have the group that's RAS-driven. We have the group that's wild type for RAS, but have alterations in the MAP kinase pathway. So other MAP kinase genes in terms of BRAF, occasional mutations, deletions, etc. That's a group of about 3%. And then we have this rare group, which is truly RAS wild type and MAP kinase wild type. And where we see the fusions, that's about 1 or 2% of individuals with pancreas cancer. And there are drugs that are disease agnostically approved, and one specific disease indication of drugs targeting these fusions in pancreas cancer. We'll come back to wild-type RAS in a minute, but think younger patients, think RAS, although recently had an older person and who lived almost to their 80s with a fusion in pancreas cancer. That's kind of rare, but we do see it in all ages. And the point here being that there's some prognostic difference between these groups, and that all RAS mutations are not alike. So comparing RAS wild type to RAS mutated disease, we see a clear difference in outcome. I'm not showing it on this slide, but that data has been shown in multiple data sets that's independent of any therapy alignment. If you look at the allele breakdowns in pancreas cancer, it's D followed by V, followed by R there in the codon 12 position. And then we see about 1% of individuals with G12C will come to the therapies targeting that in a minute, and also see occasionally G13 and Q61 and exon 4 mutations as well. So there is some prognostic difference, and Dr. Wolpin led some work in the adjuvant setting suggesting that D was prognostically worse. I think people are thinking about it a little differently, and maybe we can come back to this in the discussion because this is something we now need to know for these individuals, what RAS allele they have. But the prognostic impact is that KRAS R is looking more like wild type, and D and V are fairly close together in terms of being less favorable in outcome. So thinking about the biology of RAS, we see that this drug targets, or not this drug, but the whole pathway is sort of linear here, when in practice we know it's very complex with multiple redundancies in the pathway, but cycles between RAS on state, driving oncogenesis, growth, metastasis, and adverse biology, and off state. And this varies between alleles in terms of the degree of on-off. And this is where we've seen these drugs come to the clinic now targeting various different states of RAS and may have various outcomes in terms of their impact. So looking at some examples of this, the prototype G12C drugs were the covalent off-state inhibitors. We'll look at the data for adagrasib and sotorasib in pancreas cancer. See in G12D, one of the first drugs in the clinic, but ultimately did not proceed because of formulation challenges, was an off-state G12D allele-specific inhibitor. And moving to the mutant selective on-state inhibitors, and the terminology gets confusing, and there's different types of terminology, but targeting G12C here. And then Dr. Wolpin's going to discuss in detail the mechanism of the multi-RAS on-state inhibitors, which bind to cyclophilin, form this tricomplex, and switch RAS in a specific state. And that's a very interesting mechanism of action. And we also now have data on some of the PROTACs. We've seen some data from ESMO in 2025 and some data this afternoon as well in pancreas cancer. So why is this important in terms of how these drugs target, and also in terms of whether they target the specific allele or target pan-RAS or pan-KRAS? And this slide is from a few years ago, before we really had any clinical feel for how these drugs were looking, but I think some of the points are important. So the allele-specific drugs have high selectivity, so they're targeting one allele or two alleles very potently. They have potential for sustained target inhibition. We're seeing this in practice. They have a wide therapeutic index, so they seem to be very safe drugs. They have much less impact by deliberate intent on wild type, which is cutting out some of the toxicity, and there may be advantages with some of the combinations with chemotherapy. But the theoretic concerns, and this again we don't know in practice yet, does resistance occur earlier with the mutant-specific inhibitors relative to the pan-RAS or pan-KRAS agents? Without going through all the column on the right, just to point out the RAS wild-type part, picking out the toxicity considerations, this was a point of huge concern before these drugs entered the clinic as to whether this was going to lead to serious toxicity. Thankfully, it leads to toxicity, but has not been ultimately limiting. There may be advantages in terms of blocking multiple mechanisms of resistance with a broader compound. And again, I think there's going to be a place for both of these, but we'll have to figure this all out in the next couple of years. So there are many versions of this slide, and I use it not to illustrate the number of drugs. It's kind of dizzying now and exciting and encouraging, and to have so many drugs in the clinic in pancreas cancer and non-small cell lung cancer and colorectal cancer, but the focus is kind of really on pancreas cancer primarily these days. And just to remind us again, we've direct inhibition, so off-state, on-state, we've PROTACs, we've proteases, we've downstream targeting and combination approaches that way, and we'll speak a little bit about immunotherapy. So next poll question, what is the approximate rate of objective response that has been reported in the initial phase 1/2 studies of sotorasib and adagrasib in second-line treatment in pancreas cancer? So option 1, 5% or less. Option 2, 5 to 11%. 3, 21 to 33%. And then 4, 45 to 55%. Thanks for voting. Yes, so answer C, there are 3, 21 to 33%, so well done. That's over half got that right. And then moving directly to the data, this is the CodeBreak 100 data, and this is exciting in pancreas cancer, but the issue being that it applies to a small percentage of people with this disease, 1 to 1.5%, but just the fact that you can use a single targeting drug in previously treated pancreas cancer and see objective responses. I mean, this was notable. And just a reminder here relative to chemotherapy, when we utilize chemotherapy in the second-line setting, to see an objective response is relatively unusual. We do see a lot of stable disease. We do see some stability for a lot of patients, but objective responses is less than 10% for most people, and median time to progression is about 3 months, again, in an unselected population. So here, seeing responses in the 25 to plus %, this is the initial generation of inhibitors, and that median survivals were 6 to 8 months, and 8 months kind of approaching what we see in the frontline setting. So second agent was adagrasib in G12C, and again, slightly more potent perhaps. This may relate to PK and other considerations, a median PFS of 5.4 months and overall survival of 8 months, and generally well tolerated, mostly GI toxicities in this disease. And this is the first generation version of the RAS inhibitors, and these were off-state inhibitors, and now some of the newer agents are on-state inhibitors, and some of these new agents appear more potent. There is a fair bit of heterogeneity here in terms of the patient populations that were included in these studies. Some were earlier stage where you might expect a greater signal, but you can see the disease control rates are impressive in a second-line setting in pancreas cancer, and response rates, again, very small numbers here in the most recent one of in the 70+% range. So here's a glimpse of where the field is headed, and Dr. Walpin will speak to this in more detail, but just the highlights of this in terms of single-agent daraxonrasib in the range of 160 to 300 milligrams, 300 milligrams being the dose that's been taken forward in pancreas cancer. And a couple of observations with this data. When it was initially reported, response rate was in the low 20%, and if anything, with time, this has been enriched. And the most recent data in second line only is 35% at the 300 milligram range. And again, an impressive waterfall plot. And looking at the median PFSs, and for those that are not in the weeds in pancreas cancer, Dr. Weinberg alluded to this, but these median PFSs, it's at least double, maybe even triple the median PFS, and you can kind of guess where the OS is headed on this, exceeding, again, what's seen in the frontline setting. So this is what really got people's attention, that there's something real and something very important happening here in pancreas cancer. And it makes sense, right? I mean, this is the disease, again, of RAS, and to see this proof of principle, these multi-RAS-on targeting agents is very encouraging. And this is the RASolute 302 study. It accrued in very quick time from approximately October of last year through the summer, late summer of this year, a direct one-to-one comparison of daraxonrasib versus chemotherapy, and powered primarily co-primary endpoints in the G12X population, so that's excluding the G13, it's excluding the Q61, and it's excluding the wild type, and also excludes fusions there. They have to be treated, and compared to investigator choice. So co-primary endpoints of PFS and OS. So moving now to other strategies, this is the PROTAC, and this is data that was presented at ESMO in 2024 by my colleague Wongi Park, and this is, again, very interesting mechanism of action, sort of targeting at the protein level using the proteasome, the ubiquitination process in the cell to degrade these RAS, and that this has been shown to lead to oncologic activity. And we saw an update of this today. There were 2 posters looking at the protein degrader, one at the single agent and combination with FOLFIRINOX chemotherapy, demonstrating oncologic activity, and the other looking more at PK, looking at ctDNA clearance and other data. So certainly a suggestion here that the outcome is associated with the degree of degradation of the protein, which is more notable at higher doses. And the response rates, and there's a lot of, I think, selection into how these data are presented across the different studies, and not to say that one is right or one is wrong, but falling out in the 20+% range here for single-agent PROTACs in previously treated pancreas cancer, second and third line. We also saw a series of data sets from ESMO, a compound from GenFleet and from now developed in the US in Virstem, and it's an on-off state G12D mutant selective inhibitor. Again, high response rates of 40% in previously treated pancreas cancer. Dr. Desai, and today updated by Dr. Weinberg, presented additional data on INCB 161734, an oncovalent on-off state inhibitor, and at the recommended phase 2 dose of 1,200 milligrams as a single agent in previously treated pancreas cancer, 34%. So again, real numbers. And we saw an intravenous compound from China, probably related to formulation issues, combined with chemotherapy, showing a high overall response rate and encouraging disease control, but not mature data as yet. But that was the first kind of glimpse of combinability of mutant selective and chemotherapy, and we're going to see a lot of this over the next year. So briefly, with regard to mechanisms of resistance, these are diverse, can be defined as genetic or non-genetic mechanisms, and just some of these mechanisms here illustrated. And I know, again, Dr. Wolpen is going to speak to this in a little bit more detail. So I'll just, before we move to wild-type RAS, just a couple more comments about addressing the topic of resistance and what the considerations there might be. And one of them we already know, strong preclinical rationale for combining the non-specificity of chemotherapy with RAS, and I think those combinations are going to be very important potentially up front, and maybe for those who have a single-agent approach initially, when that time comes, could be some salvage considerations with chemotherapy. Other MAP kinase targeting agents, there's interest with immunotherapy, interest with vaccines, and interest with classical state targeting agents, and not on this list, but one where several combinations now are being looked at with PRMT5 inhibitors that Dr. Weinberg introduced at the latter part of his talk. So this is really exciting, and you can sort of sense that there's potentially options for subsets of patients where we may be in an era of non-chemotherapy based treatment, or possibly lower dosing of chemotherapy treatment as initial strategies over the next couple of years. So a couple of points on KRAS wild-type disease, again, 5 to 10%, as we said, and this gives you just a snapshot of what that looks like. The BRAF, MAP kinase pathway alterations. We see more mismatch repair deficiency, not exclusively in the wild-type state, but a bit enriched. And we see these fusions. They're 0.3, 0.4% of individuals with pancreas cancer, NRG1, RET, MET, NTRK fusions, and these are the ones we look hard to find when we don't find a RAS mutation because of the targetability. But now, as you see, we're going to have a targeted or precision medicine approach for essentially every single person with this disease moving forwards. So we saw a disease-specific approval in late 2024 in NRG1-driven pancreas cancer. Quick reminder that neuregulin binds HER3, leading to this dimerization, oncogenesis, and zetacetuximab binds the extracellular domain and blocks anti-tumor activity and it enhances anti-tumor activity. And this drug was approved based on a single-arm, non-randomized design with a response rate of 40% plus in previously treated pancreas cancer with a good durability and quite a range of durability. And this is now being used. A reminder that fusions can be hard to detect on DNA methodologies, and we need the benefit of RNA approaches, and we need the benefit also of IHC, and this goes to a degree for identifying MTOP loss. The testing is getting a little bit complicated in pancreas cancer, and I'll just speak briefly to that. So back to the topic of immunotherapy. RAS is kind of a central regulator of, badness, and there are many reasons why pancreas cancer is the prototype cold disease. There's relatively small numbers, baseline of effector-activated T cells. Those T cells tend to be geographically distributed away from the epithelial cells, low tumor mutation burden, and a lot of an immune suppressive milieu, macrophages, cytokines, adenosine, as we heard previously. But nonetheless, there are examples of being able to target oncogenes in pancreas cancer. This is kind of the early era of adoptive cell therapies in pancreas cancer, targeting G12D and other case reports with V, with HLA dependencies and seeing single-agent responses. These are encouraging proof of principle, but they are challenging, a lot of logistic considerations, a lot of resource intensiveness to do this, and various mechanisms of why they may not work, and the overlap of HLA types with the allele, it can be limited in pancreas cancer. So there's now some of the off-the-shelf vaccines that you've possibly heard about. This is work led by Dr. Weinberg, Dr. Pant, and others, evaluating a vaccine, an oncogene albumin-bound vaccine, which is kind of a unique mechanism that has a lymph node delivery system. It's being evaluated in a prime boost strategy. The initial phase 1 experience was in a small subset of pancreas and colon cancer individuals who had completed all of their therapy for localized disease and had rising biomarkers or detectable ctDNA. And with the initial vaccine, which was G12D and G12R targeting, immune response was correlated with relapse-free survival and median overall survival not reached, along with an expanded T-cell response and antigen spreading. And then with the second generation version of the vaccine, which used a higher peptide dose and included 7 RAS variants, was significantly more potent, broader immune response, and that immune response also correlated preliminarily with disease-free survival. And that's led to this study, which has completed enrollments a little over a year ago in resected pancreas cancer, not selected for MRD, but just had to have completed all therapy and just had to have a lymphocyte count greater than 1, and comparing in a 2-to-1 fashion vaccine versus observation, where the standard is observation because patients have completed therapy in that setting. So we await the readout for this. So moving to molecular testing in pancreas cancer, and as we're again now firmly in this era of biomarker-directed therapies, at least in clinical trials and hopefully soon for everybody with this disease, we need to ramp up how we do testing and when we do testing. And I think the message here is early at diagnosis, and this is now essentially for everybody with this disease. Our current guidelines are good, but I don't think they fully yet speak to the need to how we need to do this. And there are a number of things that we need to look at. And in the setting of limited tissue resource, we're a little bit challenged, and also challenged to get this information in a very timely way. So it's sort of needing multiple tools to do this. Current guidelines speak to NGS, speak to germline testing, using RNA testing for fusions, and increasingly the use of ctDNA as being the most rapid way of gleaning this information. And not to belabor this, I think the audience is well familiar with the timelines and the challenges of both of these approaches, but just to emphasize once more that tissue, especially in earlier stage pancreas cancer, can be a luxury, and that we struggle even now and even in very kind of resource settings to get this information, to know if somebody has a RAS mutation in real time. And that's something that the field definitely needs to ramp up. So I'll close with this final slide just to sum up in terms of RAS biology. And as we're talking about RAS therapies, we now need to know whether somebody has RAS mutant disease. That's not enough. We need to know the allele specificity. If they have wild-type disease, we need to know what's the composition of that wild-type. That's quite a heterogeneous group. And in particular, we certainly need to know if they have a fusion, because there are drugs today. And then there's several other things that just put in here just as a glimpse to the future as to how it's getting more complex in pancreas cancer for biomarker testing. But I think we'll take that every day with the opportunities that it brings. So thank you very much. I'll turn it over to Dr. Walpin.
Excellent. Well, thanks to both Eileen and Zev for really excellent talks. As the Car Talk guys would say, now for the third half of the show, and we will finish with some discussion of some reiteration of things around RAS and some directions that we're headed. Try to highlight some of the things that Eileen and Zev talked about, and then talk about a bit about how we're approaching this. Take a second, take a breath. We're going to do another question. Also think about your own questions, right? The questions you want to ask for this esteemed group to discuss. But here's our polling question number 4. So according to guidelines, which of the following statements is true regarding testing for actionable gene alterations in advanced or metastatic pancreatic cancer? You can see 1, it says germline for all patients and tumor sequencing for all patients, including those who with advanced pancreatic cancer who are eligible for treatment. 2 is germline and tumor sequencing for all patients. 3 is germline sequencing only in patients that have a positive family history. And then 4 is that there's no recommendations for testing in patients with pancreatic cancer. All right, good. So I think the top one is probably what guidelines will say, right? Which is you should do germline sequencing in everyone, right? Family history is not a good predictor. We should not be using that to decide who gets germline testing. All patients with pancreas cancer should get germline testing. And that tumor sequencing for all patients with advanced pancreatic cancer who are eligible for therapy. I would, however, agree with what Eileen said, which is that the second one, that this should be for all patients, is actually what I do primarily in my own practice. And I'm going to have a slide in a couple slides that sort of talks about how we handle this at Dana-Farber. But one of the top two, I think, would be correct. Okay, so I just wanted to reiterate a few points that Eileen made. This was a study that we had done at Dana-Farber quite a number of years ago now, back sort of in the 2015-16 range. And what we had done is we had a bunch of patients who were coming in with metastatic pancreatic cancer, and we decided let's do whole exome and transcriptome sequencing of their tumors, meaning sequence all the genes in their tumor, sequence all the RNA in their tumor, and can we learn some things that would be useful for therapy? And that's what this manuscript was about. This is a co-mutation plot, so each of the columns is a patient and each of the rows is a different gene. And I think these data and others, obviously too, sort of led to a few take-home messages that I think now really color what we do. One is that, as Eileen said, 92 to 95% of patients with pancreatic cancer have a KRAS mutation. So I think immediately when you think about pancreatic cancer, you should think this is a KRAS mutant disease. And not only do they have a KRAS mutation, but that mutation is generally how the cancer starts, meaning that the first event that leads pancreatic cancer to become cancer is a KRAS mutation. So this is really a fundamental part of pancreatic cancer biology. And again, I think it's why some of these new inhibitors are so exciting for us, and I think really will become the platform on which we build more effective treatments for patients. The second thing is that G12C, right, which is the target of some of the currently available drugs and that they're approved for colon and lung cancer, is only about 1% of patients with pancreatic cancer. So important, we should be looking for that. However, we really need to be thinking about medicines that will target other KRAS mutations, right? G12D and V and R, as Eileen reviewed. So a second thing is that there are 4 genes that are mutated repeatedly across pancreatic cancer. KRAS we talked about as one, but there are 3 others, which are actually all tumor suppressor genes: P53, CDKN2A, and SMAD4. And as has been mentioned, there are now therapy approaches in the clinic, in clinical trials, trying to target each of these. There are cell-based therapies targeting specific P53 mutations. As Zev mentioned, CDKN2A is deleted and a gene next to it is deleted, MTAP. And that, in our experience, has actually been up to 30% of pancreatic cancer. And there are now drugs targeting that, the MTAP deletion phenotype. And there are drugs that are trying to target the TGF-beta pathway, which is what SMAD4 is a member of. So these big 4 things are all now coming to clinic, still experimental, but coming to clinic as options for clinical trials. I think that's very exciting, a very different place than we were even 5 years ago. I think a third thing is there's a lot of germline mutations. There's a reason that ASCO and NCCN guidelines say every patient with pancreas cancer should get germline testing, right? And that's because about 10% of patients will have a germline mutation. So we should be looking for that, right? It has therapy implications that Zev reviewed, but it has a ton of implications for their family, right? Because it turns out we can actually screen for pancreatic cancer if we have a high-risk population. And these mutations can define those high-risk populations. So all patients should get germline testing. Family history is irrelevant. All patients should get it, okay? And then another thing that Eileen mentioned, which I think is very true, that is if you don't find a KRAS mutation, you should think to yourself, well, what's making this tumor grow, right? Because it's always KRAS that's making this tumor grow. What is it if it's not, right? And it turns out a bunch of the things when it's not are actually quite targetable, including some of the fusions that Eileen said. And some of the patients who can have really prolonged responses to treatment are some of these fusion patients, where you can give them an inhibitor of the fusion, ALK, ROS, others, and they can respond for a long time. So we need to be looking for those. And then another group, which we're not talking too much about today, but is that about 1% of pancreas cancer is microsatellite unstable, right? Not a huge number, but you got to find them, right? Because those patients can respond to immunotherapy. And some can respond really well, others a little less well, but you got to look for those, right? So we should always know if our patient is microsatellite unstable or not. So again, the NCCN and ASCO guidelines currently really are germline sequencing for all and tumor sequencing for those with advanced disease who you think could be eligible for therapy. Again, I would then revise that to what I'll show on this slide, which is how do we handle this? So this is sort of how we sort of parse through this. And I would actually say we really do this for all patients. So there's 6 things. And this is what I often have fellows with me in clinic, as some of you will too. I make them make a checklist. Write these 6 things down, and you need to think, have we figured out each of these 6 things for every patient with pancreatic cancer? If we haven't, then we haven't done our work, right? We need to do this for everyone. So the first we talked about is germline, right? Germline panel testing, right? There are a number of genes that are altered, BRCA1, BRCA2, PALB2, mismatch repair genes. There are FDA-approved therapies for that. We're in the upper left of the slide, olaparib, pembrolizumab, depending upon if it's a DNA repair HR defect or a mismatch repair defect. So all patients should have that, right? Check the box, you've done it, right? MMR testing, all patients should have, right? There's a variety of ways to do it. You can do it with immunohistochemistry, you can do it with PCR, you can do it with next-gen sequencing. There are pluses and minuses to those different approaches. I don't really care so much. Do it in one way for every patient, right? That way you find the 1 in 100 and you treat them with immunotherapy, right? And they can really respond, so you should find that. The third box now in the upper right, that's a little more researchy, I would say, right? So at Dana-Farber, what we've started to do is we will do reflex IHC, so immunohistochemistry, for a few things that allow us to enroll to trials. MTAP and Claudin 18 were mentioned before. We do that for everyone. HER2 does actually have an approved therapy if you find it, right? It's a pan-tumor approval. It's not pancreas-specific. Probably doesn't work quite as well in pancreas as it does in other tumors. But I think this list will likely grow with time. And Eileen mentioned some others that you could include. This is what we do at Dana-Farber. So bottom left, all patients, I would say, should have next-gen sequencing of their tumor, right? And there's a whole host of things you will find. Obviously, finding the KRAS mutation is the most common, and it will become increasingly relevant for standard of care. Right now, it's really relevant for trials, but it also will become, I think, really relevant for standard of care. And then the middle, who do we do RNA sequencing on? And Eileen mentioned this. If you're KRAS wild type, look for fusions, right? And the best way really to see a fusion is actually with RNA-based testing. Most of the targeted exome testing doesn't cover the introns well, and you will miss fusions if you only do DNA-based testing. So those are the patients that I personally do RNA-based testing on. And then the last, on the bottom right, Eileen also mentioned, is who do we do ctDNA on? Our approach has been, we have a lot of KRAS inhibitor trials. We need to get that information as fast as we can, because a bunch of these trials are actually first-line trials. And the fastest way to do that for us has actually been with ctDNA. So all patients who come in with new metastatic pancreas cancer, we do ctDNA testing on. And we're looking for, obviously, a variety of things, but KRAS in particular, because the turnaround then lets us enroll them to first-line trials. So again, this would sort of be how I would say we approach the complicated landscape, as Eileen said, for molecular testing. And to Zeb's point, 5 or 10 years ago, this slide was blank, right? How depressing was that, right? There was nothing on it because we weren't doing any of these things. And now I think it's finally full of some things that are going to really change how we care for our patients. All right, so to reiterate a little bit about KRAS and talk about that a little more. So as Eileen mentioned, I think this is a unique time in oncology, right? Meaning that you have so many different drugs to a single target all coming due at the same time, right? It's really remarkable. We have some real big thanks to give to our chemists, right, who made this possible, right? But what you can see here is there are mutant allele-specific inhibitors, as Eileen mentioned, G12C, G12D, and then there are inhibitors that will bind to and inhibit multiple mutant alleles. But each, I'm almost shocked every time I look at this, and every time I give a talk, I need to add more names to this, or letter number names at this point for these drugs. But you can just see how many there are, right, which just shows you even if half of these don't work, right, and we don't know what's going to work and what's not going to work, some of these are going to come through for us, right? There's just so much chemical matter now inhibiting RAS that some of these are going to help us, right, and they're going to help our patients. So just to go back a little bit again to some of the terminology that's used, and Eileen sort of touched on this, but just to say again, RAS is a protein in cells that's required for normal function, right? It essentially takes extracellular signals, so signals from the environment, transduces them inside the cell to tell the cell to grow, right? And we all need that, right? Our gut needs that. Many parts of our body, skin, need that because our cells are constantly dividing. But that's all dependent upon an extracellular signal, right? So it's being done in the right way, only when it's needed. And when it does that, it switches, as Eileen said, from an off state to an on state. The off state is GDP bound, and the on state is GTP bound. And it's only the GTP bound state that actually signals, right? That's why it's called the on state. Okay? And there's some proteins that help it move from off to on. So the first few inhibitors that have come to clinic, as Eileen mentioned, sotorasib, adagrasib, are allele specific, right? They hit G12C, and they're off inhibitors. They essentially trap RAS in the off setting. So it can't move to the on setting and signal. And if you could keep RAS like that, you then stop growth, and that's why you see responses, right, in these patients' tumors. Some of the newer drugs that are coming, and the one that I'll focus on in the next few slides, are actually on inhibitors, meaning they're actually binding to the GTP-bound state, and they're preventing signaling. And there may be pluses and minuses to these, and I think what we're going to learn a lot over the next 2 or 3 years is what is better, right? Is it off better? Is it on better? As Eileen mentioned, some of these are now off-on inhibitors. They inhibit both, right? Some are mutant allele specific. Some are hitting multiple mutant alleles. Some only hit KRAS. Some also hit NRAS and HRAS. Like, how's this all going to play out? I don't think we know, right? I think this is really what the next few years are going to show us, where we're going to understand how some of these differences will affect how patients respond, right, to treatment. It's exceptionally exciting to be at a point where we can start to sort this out. So to give you a little more detail, because I think these are some of the compounds that are coming to clinic the soonest, are a set of compounds that are actually called tri-complex inhibitors, right? So the drug is in the upper left of the slide. It's that yellowy, orangey color. And it enters the cell, and it actually binds to a chaperone protein called cyclophilin A, right? This is how cyclosporin works. This is not a totally new concept, right? This is actually how other drugs work too. But what it's sometimes called is a molecular glue, because it binds to this chaperone protein, cyclophilin A, and then it sticks it to RAS. So it glues it to RAS. And when it's glued to RAS, it has what's called steric hindrance, which is it's unable then for RAS to bind the downstream things it needs to bind to signal growth. So you're essentially preventing growth by gluing this random, in some ways, random protein to RAS and preventing RAS from signaling. What an amazing mechanism, right? Not unprecedented, but really an interesting way to think about how you would drug and prevent signaling from RAS, right? Which had been a problem for decades, right? Where we're unable to figure out how to drug RAS, okay? So this is a follow-up to some of the work that Eileen was describing. So what is the RAS mutation? Polling question number 5. What is the RAS mutation requirement for enrollment in the RASolute 302 trial, which Eileen was talking about, of daraxonrasib, which is one of these multi-allele inhibitors. So it's a RAS tri-complex inhibitor, the mechanism we just talked about. It binds to multiple mutant alleles, versus standard of care chemotherapy in second-line pancreatic cancer. And you can see the options 1 through 4. Okay, so I think the bottom 2 would be the most logical answers, right? Meaning it inhibits multiple RAS mutations, so it would make sense you would allow patients that have any RAS mutation. And then it turns out some of these drugs, because they bind wild-type RAS, as Eileen had mentioned, they actually can be effective in that setting too. That trial actually allowed all comers, right? So any patient with pancreatic cancer. And the phase 3 trial is going to try to see whether this inhibitor can work in all patients, or whether we actually need to know the mutant allele specifically for this drug. Some of the other drugs, we obviously do need to know the mutant allele. They only hit one mutant allele, but this one is not like that. Okay, so show you some of the data for this in a little more detail, as Eileen had mentioned. So this is from a phase 1 dose escalation study. The 160 to 300 milligrams on the left are the therapeutic doses that are thought to be likely effective based on the preclinical data. And 300 milligrams is actually the dose that was chosen, right? That was what was used in the phase 3 trial. And you can see pretty standard patients with metastatic pancreatic cancer, all who've been previously treated. And you can see to the right in the pie chart, lots of different RAS alleles, mutant alleles, right? So G12D, V, G12R. The RAS other is actually Q61 primarily, which Eileen had also mentioned. So really a variety of different mutant alleles. And I would say, as Eileen said, when we started this study, we really were concerned it would be overly toxic because it inhibits all the mutant alleles. It also inhibits wild-type RAS. And again, wild-type RAS is in all your normal cells, right? And it has particularly importance in rapidly dividing cells. And so what we saw is that you actually could give this drug. You could give it at a dose that would block tumor growth, and that there were really 4 main toxicities that we saw, right? So, and they were not surprising. They actually really traveled well with what you'd expect something that inhibits wild-type RAS to do. And that was rash, so very similar to what you see in EGFR inhibitors or antibodies. What we saw was mucositis, so some inflammation in the mouth, and then some nausea and some diarrhea. And over time, we've learned how to manage this, but these are definitely side effects that you see with this kind of inhibitor. And then, as Eileen mentioned, the waterfall plots, as you can see here, there's about a little over 100 patients in the left, and then a smaller group in the right who were treated at the 300 milligrams. You can see a lot of patients below the line, right? So there were a bunch of patients who were responding to this. And again, this was all mutant alleles. We had not seen this before, right? We'd really only seen this with the 1% who had a G12C mutation. So this was new for us. And as Eileen also mentioned, progression-free survival was in the 8 to 9 month range, also substantially longer than what you'd expect to see with chemotherapy, which also was encouraging. And that did lead to a phase 3 clinical trial, right, which Eileen had mentioned, and we just were discussing RASolute 302, which randomized patients to either getting a RAS inhibitor or chemotherapy. So if this trial was to be positive, we would then have a drug that could be used in almost all patients with pancreatic cancer, potentially all, right, and take the place of chemotherapy in the second-line setting, right? And this is a pill you take once a day, would I think really change how we think about pancreatic cancer. And I really think is the first step, right, given all the different medicines there are. And I'm just going to go through, not to show you and make you remember these things, but just to say there are now lots of data, and Eileen sort of hit on this, of different RAS inhibitors. I'm going to show you a series of waterfall plots, mostly to try to make myself feel good, because after 20 years of patients not doing well, it's nice to see this, of different G12D inhibitors. These are different drugs, right? Different drugs, all coming to clinic. So this is a G12D inhibitor called zoldonrasib. Again, a lot of patients below the line having reduction in their disease. This is the drug that Zev talked about today in the session, an insight drug that's G12D specific. Again, a bunch of responses. This is another drug that Eileen mentioned, a Veristem drug, again, G12D specific, again, a bunch of responses. This is the degrader compound, that Protac that Eileen mentioned, again, a bunch of responses. This is new territory for us, right? We have not seen this in pancreatic cancer before. We have all these different medicines coming to clinic, many of which are oral, not all, the degrader's IV, but many of which are oral, causing reductions in tumor burden. It really does, I think, signify a new day is coming. Okay, I'm going to finish with a few slides here because I would love to have more time for discussion. I put in a bunch of slides on resistance, which I think I'm going to skip so we can make sure we have more discussion time. But there now are starting to be the first data of combination, right? Trying to put RAS inhibitors together with other drugs, right? We all know that targeted therapies across diseases work for a period of time, but resistance will develop, right? And the question is, how do you start to circumvent that resistance and prevent it? So one option to doing this is actually using chemotherapy. It works by an orthogonal mechanism. There's actually some very good preclinical data for mouse models suggesting these two may go very well together, RAS inhibitors and chemotherapy. And these are some of the initial data with daraxonrasib, with gemcitabine and nab-paclitaxel. Now a small cohort, right, but you can see a response rate of 55%, and almost everyone right below the line with tumor reductions. This is another agent that we talked about before, HRS-4642, again with gem nab-paclitaxel. Again, we can see small numbers, right? Small numbers of patients. We're really at the beginning of this, but you can see a lot of responses, right? Again, a lot of responses and some deep responses too, right? This really is exciting to see. And this is now leading to multiple phase 3 clinical trials of RAS inhibitors in pancreatic cancer. There's actually not even all of them that have now been announced, but you can see trials with daraxonrasib, with the Genfleet Veristem compound we were just talking about, with others. And it really speaks to what Eileen said, which I fully believe in, which is if you are going to do molecular testing, you should do it the day you meet the patient or the day before you meet the patient or as early as you possibly can, right? Because if we're going to use these medicines, multiple of these trials are first-line trials, right? If you have a mutant allele-specific inhibitor that only inhibits G12D, you need to know that if you're going to enroll that patient on a trial, and you cannot wait, right? You need to know that data as early as you can. So getting to the KRAS mutation that's present as early as you can is key. And now there are actually starting to be studies looking at it in the neoadjuvant and the adjuvant setting, right? Can we actually cure more people, right, if we use RAS inhibitors in addition to treating patients with advanced disease? This is very early days, very early. But again, I think it really opens up a lot of possibilities when we have inhibitors that are targeted at the biology of the tumor. All right, I'm going to not do this. I'm going to not do that. I'm going to do this for 1 second. So what I think that where the field is headed, right, just showed you a half dozen or more RAS inhibitors that have waterfall plots that we would all have been envious for a few years ago, right? The question, though, is how do we do better, right, even better than that? And I think that really is this pie chart. In fact, if you want a really good overview of RAS inhibitors and RAS inhibitor resistance, this article is actually from a fellow at Dana-Farber, Richard Ebright, and Andy Aguirre, who's a lab investigator at Dana-Farber. It's a really nice review in cancer discovery if you're interested. But you can see the wheel here has a number of things on it that really are now, I think, starting to come to clinic. Chemotherapy in the bottom right, obviously important. Immunotherapy, as Eileen talked about. There's now synthetic lethal targets, which includes the MTAP deletion scenario that Zev talked about, and combinations with PRMT5 inhibitors. There really are a host now of combinations that will need to be evaluated so we can do even better for our patients. Again, hopefully leading to more durable responses and ultimately more cures. All right, I'm going to go through this, and I'm not going to talk to you about it. You can thank me later. So I'm going to finish here with the conclusions, all right, and then we'll open it up for discussion. So a few things. One, we know this, right? Tough cancer, right? A lot of cancer deaths. It will become the second leading cause of cancer death in the U.S. probably in the next 2 years or 3 years or so. And it's pretty common, right? And as Zev mentioned, it's actually increasing in incidence. We're seeing more and more of this cancer, so we really do need to get a handle on how to deal with it better. Nearly all patients with pancreatic cancer will get systemic therapy, right? It's why systemic therapy is so important in this disease. Even we didn't talk much today at all about resectable disease or borderline. All those patients get chemotherapy too, right? I mean, the risk of recurrence is so high that from dissemination of the disease that everybody needs systemic therapy. That means that, again, if we can determine better systemic therapies, we're likely to not only help people live longer, but cure more people, right? And I think that's going to be key. So chemotherapy, right, remains the standard of care for most patients. It's still how we treat most patients. But it has toxicity. Resistance does develop. And I really, really look forward to the day where I'm not given so much chemotherapy, right? I've done that for a long time. It's not what I think the future should be for us. Germline testing, all patients, right? Not debatable. Every patient that you see, you should do that, right? Tumor testing, again, guidelines are really still for advanced disease that you think are eligible for treatment. However, I really would say the same as Eileen, that we should be doing this for everyone. It's going to be relevant for everyone. And I tried to give you a little bit of a roadmap how we handle that with the different approaches, DNA, RNA, IHC, those sorts of things. Obviously, you'll come up with your own plan, but I think this is really key. We should be thinking about how to use that data in every single patient. Right? This is a terrible disease. There's not that many therapies. We need to be using the data we collect from that grid of stuff we're going to do and be constantly thinking, what can we do beyond giving them FOLFIRINOX and Gemini paclitaxel, right? We've got to be able to do better than that. So KRAS mutations, up to 95% of patients, right? When you think of pancreatic cancer, you should just automatically think this is a KRAS mutant disease. It is, right? From the very beginning, it is. And as part of the point of this session today, really showing you that RAS inhibitors are about to change in the next several years the landscape of how we treat pancreatic cancer. And clinical trials are really the way we get there, right? So really thinking, are there clinical trials either at your own center or at some centers nearby to you that you can refer your patients to? We really need to be pushing the envelope. All right, so I thank you very much for your attention. Very kind of you to listen to the three of us for the past hour and a half almost. It was really a pleasure. So again, we would love to see some questions and some discussion, so please punch it in to using the QR code below. And I'm going to go, we have a tablet here that has the questions on them, so I'm going to go check it out. All right, so as I do that, also a big thank you to Eileen and Zev again for really outstanding presentations. Okay, all right, so I'll start with the first one. Since I get to read them, I don't have to answer them. I only have to ask you guys to answer them. So this is an interesting question about ctDNA, which is that we often follow CA19-9 in patients to look at treatment response. Do you use ctDNA to do that? And what happens if you have someone who is not a producer of CA19-9? Maybe, Eileen, you can start and then.
Sure. Yeah, so I think ctDNA is increasingly being used, as we touched on in the talks, in pancreas cancer. And there's a lot of data, not just with RAS inhibitors, but with chemotherapy as well, that early declines in CA19-9 early declines in ctDNA and clearance of ctDNA is predictive of outcome in this disease, and it's an early surrogate biomarker. I think we're also using it to learn about resistance mechanisms, short of accessing the tumor, but most of all to get the information to help select treatments. Now, we're not right there today in clinical practice, but for trials, this is key. And yeah, it may be better than CA19-9, but I think for people with low volume disease, with people with early stage disease, there are limitations, even though many of the new assays are more sensitive. And I see it as an increasingly important tool for us to be using.
All right, Zev, yes, no. Do you use ctDNA to follow patients?
So short
yes,
answer,
no.
short answer, no.
Okay.
I'm not saying that doesn't have value. I do think we have gotten a little too far ahead of the data on this one. And by that, I mean, I use it to select patients for clinical trials. I use it for all sorts of research-oriented things. But I find in terms of following it serially, the way we do with CA19-9, I don't find in most patients that it's all that beneficial, because it leaves us with the same challenges that we are faced with a rising, fluctuating CA19-9, which is, what do we do with those circumstances? Do we stop treatment? Do we move on? And so, beyond the other reality, which is that it's incredibly anxiety-provoking because it can fluctuate variably. So I think in the real world, I don't recommend using it. I don't know how you feel about that, Brian.
Yeah, my one-word answer is no. Yeah, I have not been using it to longitudinally follow. I definitely use
baseline.
Yeah, I definitely use it at the baseline, as we talked about, in patients with particularly metastatic disease, where I need to know the RAS mutation very quickly, or other mutations, right? It's not, RAS isn't the only thing that's leading to eligibility to trials. But it really is key. It has been a very helpful thing to do for our patients to enroll on studies. I think that will be an evolving area, and I think over time we may start using it more routinely, but I have not done it so much. I think this is a wonderful question. So this question is that sometimes we have patients who have a biopsy of the primary. Sometimes we have patients who have a biopsy of a MET. Sometimes people recur after surgery. Do you have to test all those things for KRAS? Is KRAS, sustained across the different sites of disease? How do you think about that, Zev?
I mean, so my understanding of this literature is that there is very uniform, there is not a lot of heterogeneity as there is, let's say, in other cancers with certain biomarkers. So here, pretty much in studies that have looked both at metastasis and at primary site, if you've got KRAS in one, you've got it in the other, for the most part. And so I don't necessarily feel that you need to biopsy every single location in this disease. I think if you've got someone with advanced disease, you should biopsy that. If you've got someone who had a primary tumor in which you found the RAS mutation, and now 6 months later they have metastases, in practice, I'm not sure that much we gain from rebiopsying that metastatic disease. So I'd rather enroll them on a trial quickly, a RAS trial ideally, get them rolling on new systemic therapy.
Eileen, what do you think?
Yeah, a very high concordance between primary and metastatic disease, and it's mostly where we're seeing changes is in the setting of exposure and resistance. But this is the big question, right? How much of those resistance mechanisms are going to be targetable? I think we don't know yet.
Yes. Yeah, I would agree with both Eileen and Zev. It's the founding mutation of the disease. It's there from the beginning. It's not a subclonal event that's in there, say, 20% of the cells. It's in 100% of the cells. And so it really is not required to biopsy multiple sites. It is the same mutation. It will be present. It will be present before chemo. It will be present with after chemo. The time that it changes, which I agree with Eileen, is if you put pressure on it by giving it a KRAS inhibitor, it may then develop resistance mechanisms. And I skipped some of that work for time reasons, but in that case, we will sometimes see new KRAS mutations show up that were not there previously. So any patient who's on, I would say, a KRAS inhibitor trial, I would always think about getting genetic information after they have progression. ctDNA can be an easier way to do that. Sometimes we need to biopsy to do that, but that's when I would think about it. All right, excellent. These are great questions. Here's another one. So when we think about KRAS mutations and microsatellite unstable pancreatic cancer, how do you think about preferentially giving someone immunotherapy versus putting them on a KRAS inhibitor trial? Maybe Eileen, you can take that one.
Thank you. So I haven't had the luxury of having to answer that question yet, but I think given the data with immunotherapy and the availability of it, it's probably going to be our go-to mechanism for a truly mismatch repair deficient malignancy. And just keeping in mind that sometimes Lynch syndrome doesn't automatically mean that a person might be mismatch repair deficient. We usually want to confirm that in an orthogonal way, so they have a very elevated TMB or loss of proteins via IHC so that it's a real finding. But yes, we're coming across this in the BRCA setting. So patients with BRCA and patients with a KRAS mutation, and again, in a world of available choices, it's going to be a nice question is, which approach is going to be the one that will be the start points of the treatment strategy.
Yeah, what do you think, Sam? Thank you.
Yeah, I mean, I think an embarrassment of riches, but I think I would start with immunotherapy in practice. It's easy, quick, and they don't respond typically as well as we're used to seeing perhaps in metastatic colorectal cancer, MSI high, and even gastric cancer. But I would, in those patients, I'd get them started on the readily available therapy.
Mm-hmm. Yeah, agreed. Yeah, I think one of the things to me that stands out is the durability of immunotherapy. If it works, can be very durable, and people can respond for a long time. And if you are in the fortunate group that doesn't get an autoimmune side effect, the side effects are really quite modest. And so I agree with Eileen. I hope I have this problem and I run into this more often, but it's not that common event in pancreas cancer, MSI high, again, about 1%. So we should always be looking for it, but there aren't that many patients. But I've not truly been faced with that quite yet, where I had a trial slot for someone on a RAS inhibitor and the ability to give them, say, pembrolizumab. But I think the potential durability of immunotherapy for me, I think may have me choose that over it. All right. Maybe I'll pose this one then, the next one, which is sometimes tumor specimens from patients with pancreatic cancer, from their biopsy, whether that's a fine needle biopsy or a core biopsy, don't have a lot of tumor cells in them. And sometimes getting DNA from those specimens can be difficult. Are there strategies, or how do you guys think about this? Maybe, Zev, to start, how do you think about dealing with the hypocellular nature of pancreatic cancer and yet a strong desire to know mutation status?
So I think in your slide, you did a good job of pointing out, ctDNA, right? There's an advantage. And I think we do know in a lot of patients, they do need to start pretty quickly, right? We love to put patients in study, but we also face this reality that in some patients in the real world where, symptomatic patients, there's an urgency to start on some level. We can't sit around and wait another 3 weeks for a biopsy to come back. So in practice, I like doing ctDNA in every patient with advanced disease. If that patient has a RAS mutation, we're fortunate in that virtually every company, and there is uniform acceptance, I think, on all clinicians' behalf, that should be sufficient to enroll the patient on, let's say, a D-specific study or even a pan-RAS study. You see the KRAS mutation, that's good enough. The blood-based assay will be sufficient to enroll them. We'd rather more tissue, but in paucicellular specimens, we do what we can first, and then we deal with the tissue question later.
And maybe one point to add to that, if there's the option of biopsying the primary versus the metastatic sites, go for the metastatic sites. The yield is likely greater and less stromal components. But it is a real world problem. There's no question about this. And I think, I'll see what my colleagues think, but I would say at least 10 to 15% of people, we don't have an answer and don't have tissue, and we don't have an answer from ctDNA, and we're stuck. I mean, that's some of the advantage of maybe the pan-RAS inhibitors, and when hopefully they're available, but this will not limit their ability to receive targeted therapy.
Yeah, I would agree. The MET is better, right, just in general, because the cellularity of the METs, particularly in the liver, is higher, right, than the primary. So you are more likely to get sufficient DNA extraction from a biopsy of a Met. Also, the benefit of the liver is the core needle is larger, right, than what you get from an EUS-guided FNA or FNB biopsy. So I think whenever possible, if a patient has liver metastases, to do that. Those also happen to less so from lung and also less so from peritoneum. But I agree, I had a patient this past week that was exactly in the situation that Eileen said. I've been unable to get sequencing data. I have tried all these different ways, including a couple different biopsies, and we're just going to have to see. I'm going to keep trying, but so far I don't have it, even though I want it. I do think it is reasonable along the way to keep thinking about it, though, not to just sort of throw your hands up and say, I can't get it, I'm done. I will, over time, as the disease progresses, continue to try and hopefully get to an answer. All right, I think that is taking us exactly to the hour. So I think if folks have additional questions, come on up and ask Eileen and Zev. Thanks, everyone, for coming. Hopefully, we leave you a little more optimistic about pancreatic cancer and where we're headed. And I think really we are headed for a sea change, right, for this disease. So thank you to Eileen. Thanks to Zev for their great talks.
Thank you.
Thank you, Zev.